Okay, I'd like to thank the Sense Research Foundation for having me here. What I would like to do today is to share some of our approaches in building tissues. Okay, so as you know, cardiovascular disease remains as a leading cause, and it's continued for many years. And obviously, there have been many therapies that have been developed and which improved the situation. However, there has not been a significant decrease in mortality rates. In this area, vascular grafting, has many applications, and there are, several areas that vascular grafting is needed. Obviously, coronary artery bypass is needed in a large number of patients. Of course, there are peripheral artery needs, and in addition to that, dialysis access is also needed. And so the bottom line is, we're in a severe situation where good functioning vascular graft is needed. Now, currently, there are two types of vascular grafts, one biological grafts and one synthetic. Biological grafts are obviously the gold standard for the surgeons to make graft in patient is autologous graft, taking autologous vessel from somewhere else and use it as a conduit to make the blood flow. If that's not possible, people have used allografts or even xenografts to do that. However, there are many concerns of immunogenicity or concerns of transmission of pathogenic diseases. So those have been always been a concern. Now, on the other side, aside from biological grafts, people have used synthetic grafts, but however, those proved to be pretty good in large diameter vessels. However, for smaller diameter vessels, those synthetic grafts are not suitable. So one proposed idea, when tissue engineering became, about 20 years ago, people have suggested that maybe tissue engineering techniques could help build tissues that could be used as a substitute for vascular graft. And the classic approach of tissue engineering in building a vascular tissue is basically, take vascular cells from the patients, grow them ex vivo outside the body in large quantities, and then place those autologous cells onto a supporting structure, in this case for vascular grafts, tubular scaffolds or tubular structures consisting of biomaterials, and then these cell-containing scaffold will be preconditioning to make the cells adapt and mature, and then place the construct back into the same patient where the cells came from. So that's basically the approach that have worked, over and over again. So in order to build vascular tissue for grafting purposes, so there are three elements or components that you will need. You need cells, you need scaffolds consisting of biomaterials, and then you need a way to mature those cells so that the cells could mature and become functioning tissue eventually. So vascular cells, mainly endothelial cells, those are the cells that cover the lumen of the vessel. They're very important because they prevent the blood to become clotting or thrombogenic. Now, smooth muscle also is important because it involves in contractility of the vessel and eventually control the volume. So, those are the main cell types, and those can come from donor vessels, or, it can come from stem cells. So there are many sources that you can obtain those cells. Now, for scaffold 2, you can use scaffolds from naturally derived sources, or, for example, you could take donor blood vessels and remove all the cellular component, leaving only the extracellular matrix that looks like a blood vessel and have a consistent like blood vessel. Or you can use a synthetic material that you can fabricate them and make them into a tubular structure. However, whatever material you use, it's gotta be biocompatible, it's gotta be safe, and it's gotta have the physical property similar to a blood vessel. And then as far as maturing the cells, we have used bioreactors. Obviously, when you grow cells in vitro, those cells are not exposed to a high pressure, high flow environment. Those are normal atmospheric pressure. So even if we attach those cells onto a scaffold, if they are exposed to a high flow physiologic conditions, those cells tend to fall off. So bioreactor serves as a means to keep them and adapt to a changing environment so that the cells could maintain their adherence. So those three components: cells, scaffolds, and the means to further mature the tissue. So in terms of cells, yes, we can obtain and isolate those vascular cells from blood vessels. But many years ago, we have developed a system where we could obtain those cells from peripheral blood. Now, in the peripheral blood, there is a cell population called endothelial progenitor cells. And those cells are committed cells that eventually become endothelial cells. So instead of taking a tissue biopsy and isolate them and grow them in vitro, we thought, why don't we obtain those cells from peripheral blood? So we have developed a extracorporeal cellular affinity column. Basically, it gets hooked into an artery, and the other side gets hooked into the vein so that the blood would flow through the column. And in the column, there are several beads that are conjugated with antibodies specific to endothelial progenitor cells. So as the blood flows through, those EPCs would bind to the antibody and be selected while returning the entire blood volume back to the patients. And using this approach, we have been successful in obtaining a much more cells. When you compare it to a conventional method where you would take 50 cc's or 100 cc's of blood, take it out, and then use the Buffy code to grow the colony. Anyways, that system worked very well, and we were able to obtain and isolate endothelial progenitor cells, and we were able to also get smooth muscle cells from various sources, including a vessel itself or from stem cells. So either way, when you're trying to build a blood vessel, those cells have to be characterized and have a consistent phenotypic and functional characteristics. So once we do that, we have used various types, different types of blood vessels. We initially have used a tissue blood vessel and removed all the cellular component and used it as a matrix. However, and it worked very well, and we have used that to, for the AV fistula, for the treatment of hemodialysis access. However, using a native tissue as a scaffold is sometimes very limiting because it is very difficult to get a right size caliber and right size length. So we decided to develop a synthetic biomaterial that combined with naturally derived substance and make it a more consistent so that you can fabricate it and manufacture it in a more consistent manner. So we have initially used electrospinning technique to fabricate our vascular scaffold. Now, electrospinning technique is that it is a technique where you expose the polymers with a very high electric current, and and if you do that, those polymers tend to form fibers. And so this is the polymers. They are in liquid form, and then you give a very strong electric current, and as it gets injected, it becomes fibers, and you have a rotating mandrel that kind of collects all those fibers that eventually form a scaffold. To better fabricate for the purpose of vascular graft, we have developed a bilayered scaffold which has 2 layers. So we have made it very tight in terms of the porosity on the inner side so that the blood will not leak, and then that would also give the cells, endothelial cells, opportunity to adhere to it. However, on the outer side of the blood vessel, we made it very loose, creating more space for smooth muscle cells to be accommodated, and eventually those cells would be the cells that would be involved in contraction. So as you have seen here, the scaffolds that we have electrospun are very flexible. So we have used collagen as a natural, very bio-friendly material, as well as polycaprolactam, which is a safe biomaterial that has been used in the clinic as well. So in terms of, so we have cells, very well characterized cells. We have a scaffold that has all the ideal characteristics for blood vessels. So then those cells were placed, attached onto a scaffold. So endothelial cells on the inner side to prevent thrombosis, and then muscle cells on the outer side to eventually help with contractility. And then if we implant that construct back into an animal, now those cells will not be able to adapt to the high pressured, high flow environment, and they would fall off. So that's why we have used a bioreactor to precondition them and train them to hang on to, adhere to their surface. And as we do that, the cells would further mature and become a more tissue-like structure. So we do that for about a week or so, 5 to 10 days, and train them, and then implant that in vivo. So this is the scaffold seated with cells, endothelial cells on the inner side, over here, which with bioreactor. So bioreactor, you apply your cell construct onto a bioreactor and you perfuse it. So you have a steady flow and increased flow over time. So those cells are able to adjust and orient themselves into the direction of the flow. As you see here, you do see a nice monolayered cells, endothelial cells oriented in unidirectionally. The red color is the muscle cells that have been seeded and have infiltrated within the scaffold as well. So the next step was we wanted to see if these tissue construct, vessel construct would survive and would function normally and eventually mature into tissue. So we have used a shaped carotid artery model. We exposed the carotid artery and removed 5 centimeter of length of the carotid artery, and we replaced the vessel construct and then follow the animals. And then so we have followed these set of animals for up to 6 months, and we were able to confirm that the patency was maintained and blood flow was flowing like an arterial blood up to 6 months. Okay. So we looked at the vessel diameter because sometimes when you use graft, sometimes the construct would contract or fibrose, scar down, or it may, because of the pressure and flow, it may dilate. So we have compared the engineered vessel with the native, and we were able to see pretty consistent size of the diameter for up to 6 months here. So we then took the CT scan to make sure the implanted vessel, which is this part here, is able to, has a right caliber and is not structured down. And we were able to find the vessel that in the original shape and size as we implanted. So after 6 months, we took down the vessels and compared that head-to-head with native artery, and it had similar caliber with similar consistency, and gross appearance looked pretty similar. Histologically, we were able to find endothelial cells covering the lumen and smooth muscle cells consisting of the outer portion of the blood vessel. This is the polymers, polycaprolactone, that has not yet degraded. Now, polycaprolactone has a longer time of degradation, but they would go away in about 2 years. So it is a very good material if you want your scaffold system to last longer to ensure that the tissue is functional. We have also confirmed that their ECM organization was similar to native tissue. It's not exactly the same, but within the time of observation up to 6 months, we were able to see similar extracellular matrix organization. So through this study, the electrospun bilayered scaffolds are able to accommodate endothelial cells on the luminal side and make those cells adhere pretty tightly if you train them appropriately. And we were able to place and infiltrate isthmus muscle cells on the place where it's supposed to be. And this construct maintained their patency and structural integrity over 6 months for the entire duration of the study. And histologically, we have seen similar characteristics of native blood vessel from the construct that we have implanted. So we know that this approach, this is a classic tissue engineering approach where you would take a tissue biopsy, isolate those cells from that tissue, grow them, expand them in culture until you have enough number of cells, and then place them on a supporting structure. In this case, is a tubular shaped biomaterials, and then precondition and then implant that back into the same patient where the cells came from. However, we know it works. However, what the problem or limitation of this approach is that it takes too much time, too much resource, and so we wanted to find a way to kind of shorten that time so that we could, prepare and deliver the necessary blood vessel to patients. So, for example, by culturing in itself, it could take two months easy. And then placing the cells and then placing them, preconditioning them, it takes 2 weeks. And then after you implant it into the body, it takes many months for this construct to mature and become functional. So is there any way that we could do that? If we remove cells from this equation, because most of the time is due to cell culture and expansion. So if we do that, it would be much more efficient and better, and it can be prepared in a more rapid manner. So we have tried many different approaches, and one approach is to then growing cells is, especially for endothelial cells, is to prevent thrombosis. So if blood runs onto other surface other than endothelial cells, they tend to clot. So if we can prevent that by conjugating heparin, which is an antithrombogenic agent, onto the luminal surface of the vascular scaffold, then we can prevent the blood from clotting, but allow the blood pass through. So we have repeated the entire study that I've just shared with you, but the difference is that we have not used any cells but conjugated heparin to the lumen of the scaffolds and then implanted into the sheep carotid artery model, and we have followed the animals for 6 months, and then as expected and anticipated, we were able to see the implanted vessels maintaining their patency as well as flowing the blood in a normal manner. CT scan also shows the implanted scaffold only with conjugation is able to maintain its caliber, size. After retrieval, we were able to see similar appearance grossly, but more importantly, we were able to see the nice coverage of the lumen with endothelial cells, and over time, at 6 months, we were able to also see migration or presence of the smooth muscle layers surrounding the endothelial monolayer. So we know that by conjugating this heparin, we're able to maintain not only its function, but over time, the body is able to mobilize those necessary cells and try to repair themselves. This just shows that the implant has a similar ECM organization, but not as identical to native tissue. But as for the blood vessel, two main function is the passage of blood without any clotting, and then those blood vessels would contract and relax to control the volume of flow. So we have taken the retrieved segment and did organ-based study using pharmacological agents, and we have seen similar patterns of response to drugs, which indicates that the implanted segment has the necessary components, not quite as strong as the native tissue, but it's getting there. And biomechanically, blood has to be sturdy, or otherwise it would pop. And we were able to show that the biomechanical properties are pretty comparable. So I would like to switch gear, and blood vessel work is currently continuing to find a better and easier and faster way to bring it to patients. Now, heart valve is another important tissue that you do see increasing in numbers as people age, and approximately 5 million Americans are diagnosed with valve disease, and at least 60,000 people have valve repair. Now, there are two kinds of heart valves. One is a mechanical, and one is bioprocesses. They do work, but there are advantages and disadvantages, and eventually you will have to replace them periodically, about every 10 years. There's a limitation with the currently available therapies, either mechanical or biological. So we have initially applied the same approach, the tissue engineering concept, to build heart valve tissue by taking the cells and taking the scaffolds. As you see here, we would take a valve tissue, donor valve, remove all the cellular component, leaving the extracellular matrix intact, and then obtain endothelial progenitor cells and coat the heart valve with these cells, and then place them onto a bioreactor to train them to adhere. And if we do that, we do see a nice monolayered endothelial cells covering the valvular surface and the leaflet. Now, as indicated, it just takes a lot of resources and a lot of time and a lot of work. So we were looking into a way to shorten that process and make it simpler. So what we have done is we have conjugated the valve scaffold with CD133 antibody, which is a specific cell marker to endothelial progenitor cells. And so you bind antibody so that as the blood flows, through the valve, those floating cells, free floating cells, will be captured by the antibody, and eventually you'll have a self-seating, heart valve. So we did that. We have then implanted into a shape model and have compared different methods, and we were able to show that even at 2 weeks we were able to see endothelial cell progenitor cells covering the surface of the heart valve, and the cellularity increased, and those cells penetrated over time. histologically, we were able to see at 2 weeks, we were able to see that those cells attached onto the surface are endothelial progenitor cells, but but after a month, those cells have differentiated into fully matured endothelial cells as seen here. But more importantly, biomechanically, the conjugated heart valve is pretty similar to a normal valve, as you see here, and we do see evidence of tissue remodeling over time. So we are very excited because by doing so and eliminating the cell component from this equation, we're able to save a lot of resources and bring the technology faster to patients. So in conclusion, we have used a tissue engineering approach to build many different tissues, including cardiovascular tissues, and we know that cell-based approach works, and you eventually end up with a good functional tissue. However, besides what I have shared with you, there are many and new innovative technologies that are constantly being developed to bring better technology to patients. And these technologies, although these are at early stages of development, they could eventually become a standard in treating these, disease pathologies. So besides those, we are working on many different areas and many different tissues, and those technologies that we develop in the lab, there are multiple applications that we have brought to patients, but however, there are many more technologies that we're currently working on, and the status, the progress is different for different organ and tissue systems, and no tissue is easy and simple. Lastly, I would like to thank our lab members. We have over 300 individuals working only in regenerative medicine in order to develop these therapies and bring these therapies to patients sooner and faster. Lastly, I'd like to thank our sponsors who share the same vision as we do, because no money, no research, no product, right? Thank you very much.